Good afternoon, everyone. I'm Dr. Praveen, Manager Market Access and Advocacy, SAT India. On behalf of SAT and AVO Alliance, I would like to welcome you all to this live webinar series on advances in casting and splinting. A quick introduction about SAT and AVO Alliance. SAT is a global hygiene and health company headquartered at Stockholm, Sweden, and has presence over 150 countries. While AVO Alliance is a developmental non-profit organization dedicated to improving the care of the injured in low and middle income countries. This program is a sixth in a series of live webinar programs happening every Saturday from 1 p.m. to 2 p.m. And in today's program, the session would be on conservative management of pediatric fractures. And leading this session, I would like to introduce the faculty and welcome them. I would like to welcome Dr. Vikas Basa, who is a consultant pediatric orthopedic surgeon at Kokilaben Dhirubhai Ambani Hospital, Mumbai. I would also like to welcome Dr. Taral Nagda, who is a professor of orthopedics and pediatric orthopedic surgeon at Jupiter Hospital, at SRCC NH Children's Hospital, and also the director of Jupiter Gate Lab. We are also privileged to have a very senior surgeon, Dr. Theddy Slongo, who is a senior consultant and pediatric trauma and orthopedics at University Children's Hospital, Bern, Switzerland. We welcome you, Dr. Slongo. I would also like to welcome Dr. Pabin Thapa, who is an assistant professor of orthopedics at Manipal Teaching Hospital, Nepal. Now I would like to share the brief agenda of the program. The program would start with Dr. Basa giving an introductory talk on basic principles and conservative management in pediatric fractures. That would be followed by Dr. Slongo's session on biomechanics in casting, where he would also show videos demonstrating a Combi-Cast technique with plaster as well as synthetic cast material. The third session would be a clinical case-based discussion, which would be led by Dr. Taral Nagda. Subsequently, Dr. Theddy Slongo would again share his thoughts on when plaster treatment does not work. And the last segment would be question-answer session, where all the questions posted by participants would be addressed by the faculty. So I would request all the participants to share their questions and post them in the question box below the screen. Now with this, I would request Dr. Vikas Basa to start the session. Over to you, Dr. Basa.
Yeah, thank you, Praveen. So, yeah, thank you, SCT, for giving this opportunity. And warm welcome to all the viewers and the panelists. Myself, I'm Dr. Vikas. I'm a pediatric orthopedic surgeon at Kokilaben Dhirubhai Ambani Hospital in Mumbai. So I'll be talking on this, the first topic is principles in management of fractures in children. So right from the gestation up to the skeletal maturity, the growth and development is constantly creating changes in the skeletal system that distinguishes a pediatric patient from the adult. So since they have a huge potential for healing and remodeling, the absolute anatomical reduction of the bone is far less important as compared to the adults. So I'll take you to the journey of this bone, how it heals, and what are the principles in their management. So the physis and the epiphysis, these are the unique features to the skeletally immature bone. The physis constitutes the growth plate. It is cartilaginous in structure. It is unossified. So it doesn't cast shadow on X-ray. It is seen as a radiological gap. So a few times it is interpreted as fractures in some areas of the bone. So the thorough knowledge of the skeletally immature bone anatomy is very essential. The growth plate, which is actually a beauty of the growing bone, is very unique. The structure of the growth plate varies in different age groups and in different areas of the bone. In infants, it is quite stronger than the bone itself, and it has a huge remodeling power because it constitutes the longitudinal growth of the bone. So whenever a fracture occurs through the physis, when the vascularity is disrupted, so it can lead to physeal arrest and results in shortening or the deformities. But in few fractures, like in femur, sometimes a fracture around the growth physis can stimulate the growth, and we see an overgrowth or lengthening. So the pediatric bone, the water content is more as compared than the mineral content. So there is an increased proportion of the collagen that makes lower modulus of elasticity, so which makes the bone less brittle. And the bone is more porous. They have a lower tensile strength. So the tendency of the fracture to propagate is far less. So that's why usually we don't see accumulated fractures in children. But however, the bone fails both on tension as well as the compression side, resulting in buccal fractures. So the cartilage, which is actually the unossified portion of the bone, which is mainly at the articular ends of the bone, it has a better resilience power. And it is very difficult to view this structure on the X-ray because it is unossified. So sometimes the articular fragment size is underestimated. So for that reason, we need a special imaging like the arthrogram. You figure out the exact size of the fracture fragment. The periosteum, which is the beauty of the growing bone, it's highly vascular, it is metabolically active, and it has a huge osteogenic potential. And it is firmly attached at the physis and envelopes the entire bone, except the articular surfaces on either ends. So in the low energy fractures, usually this periosteum is often intact on the concave side, which often helps in fracture reduction, and it promotes a rapid healing. And the periosteal new bone formation contributes to the great extent of the remodeling of the bone. So in different age groups, the fractures at different sites are common. So like I said, in infants, the growth plate is a quite strong structure. So we don't see fractures around the physis. It's usually the diaphyseal fractures. In the childhood, the fractures are common around in the metaphyseal regions. From child to the adolescent, there's a transition period. They have changes in their hormones in their body. So which makes the physis a very weak link. So that's why in adolescent age group, the physeal fractures are common. So usually in these age group, we also see a slips of the physis. And the blood supply of the pediatric bone is quite different from adults. So they have a very rich blood supply. The metaphyseal vessels, they send capillary loops which end in the physis. And in infants, you may see even these capillary loops, they traverse the whole physis and they supply even the epiphysis. So this abundant and rich blood supply, because of this, they have a far less incidence of delayed union and the non-union in children. So these are the few fractures which are unique and common in skeletally immature. So we'll see them in brief. So the buccal fracture, the torus fracture, it occurs usually at the metaphyseal diphyseal junctions. It is quite stable. It is mainly because of the failure on the compression side of the bone. And usually it doesn't require any manipulation unless it is very acutely angulated. So otherwise, just a cast immobilization for a period of 3 weeks heals better. The green stick fracture is actually an incomplete fracture. There's a break only in one single cortex. The other cortex is usually intact and it goes into plastic deformation sometimes. So it is due to failure on the tension side of the bone because of the bending force. This is also quite stable. You don't require any manipulation. Cast immobilization is what is required. But when you see a fracture like this, wherein there is a comminution and acute angulation of the fracture, so here you need to complete the fracture so as to realign the bone, which promotes faster healing and prevents the deformity. The plastic deformation, which is uniquely seen in pediatric bone, it's predominantly due to micro cracks and it is irreversible. And this deformity is sometimes even can become a permanent because it doesn't remodel well. So that's why it needs a correction and a manipulation. And this type of plastic deformation is seen commonly in bones of the forearm and in the fibula. So traditionally, it is said that primarily the fractures in the physis occurs to the zone of hypertrophy, but the recent studies have shown that the fracture may run even through other zones of the physis as well. So you need to be utmost vigilant in reducing these fractures anatomically because they do not remodel well. and to prevent the deformities. So way back in 1963, Dr. Robert Salter and Harris has given the classification of the facial fractures from 1 to 5, and later they added the 6th type, which is the fracture around the perichondral ring. So you need to develop a skill to examine an injured child, because they usually don't give a consent because they're in agony and they're in pain. So you have to develop keen diagnostic skills to examine them. And you cannot rely completely on the parents, because usually they're not present at the time of injury. So they may not provide you all the complete and the accurate history. So it is our duty to examine them properly by taking them into confidence that you're not going to do any further harm to them. So you need to be very gentle, very carefully assess the deformity and the tenderness, and completely, you examine the entire limb as well, and look for the bruises anywhere, because sometimes whenever in doubt, if you suspect a child abuse, it is always better to see the other parts of the body as well as in the same instance, because not only as a treating surgeon but as a responsible citizen, it's our duty to protect them from any unhealthy environment. And while you're talking to them, carefully assess and document the distal neurovascular function. You may ask them to do a few actions of the hand to see the integrity of the nerves. You may ask them to make a fist, a thumbs up, or ask them to make a star. Or you can assess all these three together with one single action. You may ask them to tell if are they okay. If they do this, this is called an okay sign, wherein you can check the integrity of all the three nerves. And my trainee doctors usually interpret this as a RUM sign. RUM stands for radius, ulnar, and the median nerve. And in the lower limbs, you can check the integrity of the nerves by asking them to make the movement of the ankle, the dorsiflexion, the plantar flexion, the movement of the toes. When you see a fracture like this in children in ER, please don't rush to reduce the fracture. So here you have to follow some principles. Give a profuse wash with normal saline, give a tetanus prophylaxis, and cover the bone with the normal saline soaked gauze piece and give a back slab, and take them under anesthesia. Explore the wound, because sometimes you may have to do a minimal local debridement of the bone and repair the ruptured muscle in the tendon and stabilize the fracture with external fixator. So follow the rule of 2 whenever you're radiologically evaluating any fracture. So always remember 2 views, AP as well as the lateral view. So when you see this AP view, the bone looks perfectly all right, but you can observe and you can make out there is a fracture, undisplaced fracture, oblique fracture in the lateral view. So if you don't see the lateral view, obviously you're going to miss the fracture. So that's why always evaluate any fracture in 2 views. And always 2 joints, because sometimes there may be fracture in the epiphysis up or down. So always the joint above the proximal and the distal joint has to be visualized in the X-ray. So sometimes the children, they may have certain deformities. So to compare, you may take the X-ray of the other limb to make sure that it's not a fracture, or you're not dealing with any other thing. And if you're reducing the fracture in the ER, it is always important to take post-reduction X-rays to see whether it is acceptable. And whenever in doubt, take the opinion of your colleague or the seniors before sending them off. And sometimes you need a special imaging like arthrogram or MRI to evaluate intra-articular and to see the fractures through unossified portion of the bone. So the treatment principles is, whenever possible, always restore the length, alignment, and the rotations. Keep the residual angulation as minimal as possible. If required, you may remanipulate before 3 weeks, or you may make wedging in the cast. But when it comes to the rotation, do not leave any rotation unaddressed, because that is the thing which remodels least. And it is very mandatory to anatomically reduce the intra-articular fractures. So usually in children, we do not require any fancy implants to treat the fractures. When you reduce them near normal, and if they are stable enough, you can treat them in a cast immobilization. That's the commonest method. But when you apply a cast, you have to follow a few principles. Like it has to be, for example, in the forearm fractures, you have to maintain the cast index to 0.6. What I mean by that is the inner diameter of the mediolateral diameter inside the cast has to be wider as compared to the anteroposterior diameter, because this helps in spreading the interosseous membrane that can maintain the radial bow, and the ulnar border has to be straight. And the distance between the skin and the cast should be very minimal. It should be a firmly applied cast. So with these methods, it is very unlikely that you'll lose the reduction. But whenever you reduce a fracture very well, you can maintain that in a well-molded cast or the splint. And if you can maintain this for about 3 weeks, you're almost done. I mean, the fracture unites and it later remodels. So whenever there's a swelling, you can reduce the fracture and put a cast, but make sure that you split it open if you anticipate a compartment syndrome. So you can split open the cast and secure that with a bandage. And as the swelling reduces, you can tighten these bandage and complete the cast once the swelling is completely reduced. So by this method, you can safely immobilize and maintain the reduction of the fracture until it unites. So this can be done even with the fiberglass cast as well. So when you're treating the fractures conservatively, so you have to be smart enough to see that how the fracture is behaving within the cast. So it is your duty to see, take a serial X-rays every week and see if you're losing the reduction. If that is so, then you can remanipulate up to 3 weeks before you see the hard callus, or you can make an appropriate wedges in the cast and maintain the reduction till it unites completely. But always remember, do not remanipulate any facial fractures beyond 5 to 6, 7 days, because you'll be causing more harm to the already damaged physis by causing further damage. So as a rule, do not attempt any manipulation of the facial fractures beyond 5 to 7 days. So I shall remain incomplete if I don't talk on the remodeling, because it's a beautiful thing which the God has given for the pediatric bones, the growing bones. So it occurs usually by the longitudinal facial growth and the periosteal new bone formation. Younger the child, greater the remodeling power, and the remodeling is greater at the ends of the bone near the growth area. The remodeling is more likely if at least more than 2 years of the growth is left. And like I said, the fractures on the either ends remodel well as compared to the shaft fractures. And the angulation in the plane of the movement of the joint is well accepted, and it is well remodeled, but not the rotation. So you have to be utmost important in aligning the rotations properly. So this is one example, like a 2 years old child. She was very obese. You can see in the lateral view the muscle bulk. So I've reduced this fracture under anesthesia, but I was not happy when I came out of the OR, because this the comminuted fragment, this was actually not allowing a complete near normal reduction. But I was quite sure that for this age group, for the 2 years, and the fracture is in the metaphysis. So I accepted that, and I applied a single hip spica. And at 3 months, you can see a beautiful callus formation and the periosteal new bone formation. At 1 year, it's very difficult to trace the fracture. And the child has no overgrowth, and she's walking well. There's no limb length discrepancy. So this is the beauty of the remodeling. So at the end, I would like to say that it's good to be young. I wish I go back to my childhood, because they have a huge potential for healing and the remodeling. and they require a very shorter immobilization time because the healing potential is very high. So anticipate remodeling only if they have at least or more than 2 years of growth left. Otherwise, you have to reduce the fractures anatomical so as to heal them faster. And sometimes the fractures in children, they stimulate the growth, for example, in femur. And the ligaments are as strong as bone. So that's why, and they're very flexible. So that's why stiffness is not a problem after the immobilization in children. So thank you very much for patient hearing. And over to Dr. Slongo now.
Thank you, Dr. Basa. Now we request Dr. Slongo to start the session on biomechanics in casting.
Good morning, everybody. Let me go to my talk. Biomechanics casting. You heard before in the talk that the casting is important, but very often a casting is insufficient and cannot stabilize the fracture. Therefore, it's important to see to know some biomechanics about casting. What means biomechanics? If you look at this picture, you see this is a cast, but for what is this cast? That when you see such a cast, I guess this child never needs a cast because he's walking on this soft cast. So what means biomechanics is biomechanics and immobilization. So we have to combine this, that we have a combination of both. So mechanics is a science which deals with the principle of forces and motion of a body, and this is different. The body is moving in the cast, and we have to reduce this moving in the cast with a good biomechanical principle. And the body in mechanics is an object on which forces may act. This is the situation. So you see in this picture, we have the dynamic situation and the static situation, and we have the biomechanics of both. And we have to see how we can deal with this. What means dynamic? Dynamic is in the body. The forces in the body are balanced between action and the reaction. That means the muscle actions we have always also in the body, and this is what we have to know. And on the other side, we have then the static, and between the both dynamic and static, we have equilibrium. So the static situation then is the force in a body, action and reaction are disbalanced. This is important. So the biomechanics overall means that the implementation of mechanical principles into biological material, that in our situation is the plaster cast. With the plaster cast, we have to immobilize the body. Okay, so we have a fracture. Of course, how we can deal with this fracture or stabilize this fracture, this is a method. We can make a traction. A traction, of course, can immobilize a fracture. But then the patient has to stay in bed for a long time until it's healed, of course. And this is biomechanics. On the other side, of course, we can deal with immobilization tools in casting materials. We can have bandage, pre-contured splints, casts, and so on. There are different options we will see over this talk. But, biomechanics, that means the immobilization and the mobile body, this creates a stress on the situation. So stress, a body is a static condition subject to external loads, will be in equilibrium under the action of these loads, and however, if the material is to remain continuous in structure, internal forces must be set up to resist the external loads. And the intensity of these internal forces is termed as stress and is expressed as force. We know it from Newton. Okay, as an example of stress, we can have tension in the body and the bone. We can have compression. This is a stress as well. We can have bending forces. We have shear forces, torsion forces, and torsion and compression. And with all this, we have to deal when we try to immobilize a body with plaster cast. with an external fixation. This is very difficult. So what is the result of a stress? You see this. If you make your plaster cast in a wrong way, then he will break. The stress of the body and what happens inside is clear. The body, the bone will not heal, or will heal in a malunion. So be careful. So again, if you make such a plaster cast, this is for nothing. Then you can make only a bandage. So this is not the plaster cast we like. What is strain? Strain is a measurement of the distortion, deforming a material, and it goes when a stress is applied to it. So young modules of elasticity is the relation between stress and strain. So this is special in kids, we have to deal with this. And the high models indicates a rigid material, whereas low models will be a flexible material. So we have to discuss stability. What is stability with the plaster cast in this situation? You see this very nice X-ray. This is very well molded. And what mechanical principles we have for good stability? This is a 3-point contact. And if you look at this picture, this is exactly what we have in elastic nails. In elastic nails, we have always, and you fix it always with a 3-point contact. And the same principles we have to deal with in a plaster cast, of course. So you see here, this is what we have to deal with. When you have seen before such a fracture, perhaps a metaphyseal fracture, by the periosteum you can reduce it, and you have to hold it. And this, never forget it, where you have to apply the forces for this 3-point contact. This is from Charlie, in Charlie textbook, 1950, this is a very old message that is still correct. Even today, it's correct. So even for all fracture, never forget that you need this 3-point contact to hold the fracture in alignment. This is very important that we do this in this way. And nowadays, and we will see a video about this, nowadays with the modern material, it's very easy to do this, to apply this 3-point contact. Today, the modern cast is not only plaster of Paris, it is fiberglass cast. But the best way is a combination of a soft fiberglass cast with a hard, rigid fiberglass cast, and we call this Combi-Cast. This nowadays gives the highest mobility with the highest stability. So we can have a function and stability at the same time with the modern cast we have today with the fiberglass cast, what is not possible with plaster of Paris. So this adaptation of cast to changing shape during muscle activities, dynamic pressure, venous backflow, reduction of swelling, less pain, vascularization of the fracture site. When we are speaking about the normal plaster of Paris, we have to remember this man, Matthijssen, in Netherlands. He was the first man who was using plaster cast. But then later on, this man was coming and he was speaking about the immobilization disease. And they realized that this kind of immobilization has some dangers on the muscle, on the tendons, on the ligaments, cartilage, periarticular areas, and the bone. So then the fiberglass cast came in the 1970s and allows early weight bearing, strong, water resistant, light, easy to use. So this then solved the problem we had with the non-plaster of Paris. So modern closed primary fracture management means optimal alignment, optimal stabilization, optimal swelling management, and early active pain-free motion. And our kids, they like to move. They don't like to stay in the bed. So for casting, there is in the AO a very good book now. Please consultate this book. It's also online available. Thank you very much for your attention. Okay, so in the next step, we will go and see some casting. So I will start now with a normal UL splint for an ankle distortion, a plaster cast, how we do this with normal plaster of Paris. I hope you can see it. It's okay? I will start. It's okay? Good. So here we prepared the material. I will do this with a UL splint. You see, we have here the normal plaster of Paris. In our clinic, we have longuettes, prepared longuettes. I measure the length for the L and the U splint in advance, perhaps, and this is a good option for a distortion, not of a fracture of the ankle joints. And then I prepare my longuette here. In this way, of course, this is very helpful if you have this prepared longuettes. So it's much easier. But here I show you how you can do this when you have no longuettes, you have only bandage. So you measured this and then you create your longuette by yourself. And it is very important that you prepare all your material in advance. Once you have started to make cast, I guess then you cannot prepare material and then you create stress. Casting means also stress-free working, very quiet, as you see it here. So now it's a small leg, so I prepare the L shape. This is the L, and this is for the U. I give this a little bit wider. I see I can prepare it in this way. This is normal plaster of Paris. Now we have tubinets for the leg, and then the soft band for a padding. It's very important that the heel is well padded, especially also in kids. Of course, I know in your country perhaps you have not this synthetics padding, but anyway, padding is very important, not too much, but not too less. So for this, I go around in this way. Okay, so that's it. Now, in the next step, we start with the U splint. We go in the water, we bring the water out, the splint all together, starting with the U splint. From the medial side, I show it here. Your assistant hold it in this way. You can do this in, of course, there are different ways. You can support the knee. Okay, it's correct. And then without folds, this is important. You see no folds in the plaster cast. Now I take the U1, the L1. Okay. And you see the patient is in a supine position. Okay. You are asking why I have more tubinet. You will see this later on. For what is this long tubinet? This is a trick I will show you. Okay, now the L splint. Very nice. Okay, no folds. Okay, you adapt it. Very nice. And then with a paper bandage, it's very easy with a paper. We do not take cotton for this. No, a paper one is much better and cheaper. We fix the splints, around here. Okay. This is now fixed. Then we bend the tubinet, and now you have to hold the foot in a plantigrade position. The best is you do this with your hand in this way, not with the finger. And now you see what I'm doing with the rest of the tubinet. I bring it over the plaster cast. This gives an additional layer and more stability. And for the patient, it's very helpful. You have no plaster cast to the clothes. So it's a very nice combined situation. You see, then you can protect the plaster with normal elastic bandage. In our clinic, we have cord, and it looks very nice. And so the ankle joint is immobilized in a good way. For removal, you have to cut only anteriorly, because anteriorly you have no plaster cast, and then you can open it and remove the leg. Okay, that's that is the first video I will show you. So in the next video, I show how we do this with a Combi-Cast. The same, I will say, okay, just a moment. Okay, so in this situation, the patient is sitting. You see, is sitting on the table. We say, okay, he has a problem in this ankle joint, and the surgeon is sitting also on a chair, and the foot then goes to the knee of the surgeon. Okay, first of all, we have to protect by the tubinet. Again, in this way, of course, you can do this all the way up to here. And now the foot goes on the knee, with the toe on the knee of the surgeon. To avoid wrinkles, you know, this is a very good trick. You cut a tongue like this, and then you have no wrinkles. You see, this is important, because with this cast, the patient is able to walk, of course, and you pat the leg in a good way, not too much in this way, because we make a Combi-Cast. That means we are using soft cast and fiberglass cast. So only for the video, I start now with the soft bandage. This is a colored that you see it much better than a white one. It's better for the video. So you give 1 or 2 layers, only 1 or 2 layers up to the proximal tibia, as you can see it here. Okay, and this is soft. You know, this is soft. And now in the next step now, we give the fiberglass, the hard part, and we prepare 2 layers. You can do this as a U, as we have seen before in the Plaster of Paris. You can go around the foot, but we plan that the patient can walk in a shoe, so we give it only on the side. You see, so these are also prepared longettes, but if you have not prepared longettes, you can do this by yourself. So one goes on the lateral side. This is hard. This is like you build a bridge. You know, the bridge, an elegant bridge, you give only a small part, but in a good way. So this gives a high stability. So we fix the lateral one with a soft cast again, and then we add the medial one. You see, the medial one. Okay, this is, as you have seen in my biomechanics talk, this is the Combi-Cast. At the end, we have function and stability. So this is important. Temporary apply very wet cotton bandage. This is important for all fiberglass cast. Even you are using only hard cast. The cast should hold or fix the leg by technique and not by weight. So this makes a chemical process of the bandage. You can remove it after 3-4 minutes, and then you can see that the different layers now are fixed much, much better. You see? So this gives a higher stability. So we create this. But you see, in this situation, we have a wide or a thick part. So we cut it away, make it smaller, fine, in this way. Okay, and now this is very soft and stable. So the patient is able to put on a screw. For removal, the patient is in prone position. You need only a scissor, because here is all soft, it's not hard. So you can open it, you can make a functional cast, or you can do this for removal in this way. So this is very elegant, stable, and good how we do this. So we can remove this in a very easy way. Okay, so we came to the third one. A long arm plaster cast, how we do this in this way. Okay, I hope you can see it. You see it? It's okay?
Yes. Yeah.
Okay.
Yes, Doctor.
So we have also protected the thumb. I will go back again shortly that you see it. How we do this, you see, we prepare a small tubinet over the thumb in this way. And we have the finger traps. You know, I do this always in the finger traps, then I can work by myself. I don't need any help. Okay, so then padding around the wrist and the whole arm. We do always long arm cast, never short arm cast or forearm cast, because a child's arm is very small. And with the long arm cast, we will protect or reduce pro and supination. And here again, you see, we prepare our splints, and this is for stability, that we need less material, you know. That means we make a circular cast, but only with 3-4 layers. And the stability is given by the splints. Again, it's like you build a bridge, you know, and this is important. And the preparation is important. So you see, and we start then always with the Waller one. So, okay. So we start with the bandage, okay, only to one layer up to the humerus, you see here, and not on around the hand. This helps you to that the splint is fixed. A lot of people are starting with the splint first, but this makes no sense. And you see, I start with the Waller one. So I have not to hold it. Then I start with the dorsal one. I adapt it, and he's fixed to the bandage, so it does not fall down. This gives the stability for the plaster cast. So it's very nice in this way. And then we finished this with only 2 layers, circular layers, not more, because the stability is given by the splints. Okay, here and here we go around. This makes it smooth and very nice. Okay, then then we make tests. Then we remove the finger traps, bring it back, remove it. Okay, and it looks very nice. And we protect the plaster cast also with an elastic bandage as well. As you can see here, movement, finger must be free. It's very elegant, not heavy. Again, stability is given by techniques. Okay, that's it from my side for the videos. I hope you enjoy the videos.
Yes.
I give back to the moderator.
Thank you, Dr. Slongo. Now I would request Dr. Taral Nagda to initiate the clinical case-based discussion.
So as we are starting this, I have a question for Dr. Slongo. We want to start with a question. Dr. Slongo, when you give fiberglass plaster, you put the roll first and then you put the slabs.
Yeah.
When you put the plaster of Paris, you put the slabs first and then you put the roll. So what was the reason for that?
No, you have seen, even in yeah, in the lower leg, this depends. Sometimes I guess it's also good for a plaster of Paris that you bring first one layer of the rolls so that the splints are fixed to the body. Otherwise, everything falls down, and this is the reason. But in the fiberglass cast, it's important because nowadays we are working always in 100%, not with only hard fiberglass. We make always Combi-Cast. Makes it easier. Removal is easier. You can cut it only some between the space. So that means we start with the soft bandage, 1 or 2 as you have seen, for the long arm cast, for a long leg cast, and then we give the fiberglass splints for stability. This gives a stability, and then we give again a soft cast. So this gives the same stability. I see very often in our country, but also in all other countries around the world, using only fiberglass. And this is so hard, and you have to cut it then with the saw, and this is not very nice for the patient. This is the reason why we go for combination. And I guess even in India, you have fiberglass cast. Ask the company you get this material, ask for soft cast, and then start to make this combination between soft and hard.
Thank you so much. So I would request Dr. Pabin, since Dr. Slongo has been talking about Combi-Cast, be a little softer to us if I exceed my time a little bit, because this is a case-based discussion. I'll try to be on time. We are going to be discussing fracture shaft femur in children, because that's something, there are a variety of treatments which have come over a period of time. So I just want to share a little bit of history. India's first pediatric orthopedic hospital, children orthopedic hospital in Bombay. It started in 1948, and Dr. Mullah Firoz was the lady pediatric orthopedic surgeon, and her birthday is celebrated as a National Cerebral Palsy Day. And today that hospital has been converted into a huge multi-specialty children hospital where I work with a team of pediatric orthopedic surgeons. And this hospital has seen the trends changing. And when you want to know what is the current trend, one way is to go to the literature and see what is the current trend, look up the journals and books and see. But another way is to go to social media, Facebook, WhatsApp groups. And this is where you come to know what is actually happening, Dr. Slongo, in management of fracture shaft femur in children. So somebody has put a case of 5-year-old child with fracture shaft femur. And immediately the answers which come are, nailing. 90% of them want to nail. 5-year is a transition zone. Of course, there is a place for conservative treatment, but there are some people who do want to nail. But even a 3-year-old child, people want to do elastic nailings. And this is a trend which is going on now. And we also see a lot of complications of elastic nailing when done for indications where they are not called for. So, I went back to the literature and, wise words by Professor Saheli. He has 2 excellent books which we follow. And he gave 4 golden words. Any fracture treatment you do for shaft femur, it should control alignment and length. It should be comfortable for child. It should be convenient for the family. And it should not have any psychological effects. And when we saw Dr. Slongo give those beautiful plasters, I'm sure that all of them follow all 4 C's which have been written over here. Now, my way is little different, clinical way. And the young boys, when we coined this sort of short term or mnemonic called LSD. Dr. Thapa, this has nothing to do with the drug abuse substance available, but LSD is for length, stability, and deformity. So if you can fulfill LSD for fracture shaft femur, and these are the guidelines we know, then you have succeeded. Method may be any, but if you achieve length, if you achieve stability, and if you don't allow deformity to happen, then the treatment is successful. We all studied that these are the age groups for spica, from 1 year to almost 5 years. And if the child is more than 7 years, we go for dental fixation. In between, you have age groups, where it's a no man's land. But in this era of COVID, the indications are being extended. You do tend to do more conservative management because you don't want to give anesthesia or hospitalize the child. And in some cases, you do extend the surgical indication. So we go over to the faculty. I would also request the audience, when I'm asking a question, ask your heart, what will you do in this situation? So this is a 6-year-old child with fracture shaft femur. I want to ask Dr. Thapa straight away in Nepal. How would you treat this patient? I'm giving you 4 options here. Action with Thomas's splint, traction followed by spica, immediate spica, elastic nail, or external fixation. What will you do?
Probably at this age group, 6 is like you can go both ways, conservative or nailing. I think at this moment we are more into the elastic nailing, so I'd directly
Elastic
go for
nail?
elastic nailing.
Vikas, quickly. Dr. Slongo has showed us his choice, which is elastic nail. Yeah. Because what would be your choice? No, we can't hear you because it's on. Please unmute yourself.
Sir, I would go with the elastic nailing.
Okay. So anyway, this child was being treated in, they had an injury in a remote place when the family had gone for holiday. Elastic nails are not available at such places, but plasters were available. And this was the plaster which was given. So Dr. Thapa, do you think this is all right in a 6-year-old child? Yes, Dr. Slongo, come. Yes.
This is a very good comment you made. So you said elastic nailing was not available.
Yes, sir.
Since 30 years, I teach always that when we go for elastic nailing, that means as in technique, the material or the instrumentation is not as important as the technique. That means even you have not the original elastic nail as we have, a titanium nail, you can use this technique. If you have in a 6-year-old child a Kirschner wires of 30 centimeters or a nail of 40 centimeters, perhaps 3 millimeters thick, you can do the same with a normal Kirschner wire if you make the technique in a correct way. That means the 3-point contact.
Excellent.
Only to say, even in a clinic, you have not, nowadays, you should know that this is a technique. Material is of second importance. Important is the technique.
Excellent. So, it's not essential that you must have the titanium elastic nail. If you have thick wire, brush rod, ender nails, anything will do, provided you follow the principles.
Exactly.
That's an excellent suggestion.
3-point bony fixation.
Absolutely. Because
exactly.
Just
a moment. Even you have the original nail and you do not follow the principles, you will fail.
Excellent. So the man is more important than the machine. That's exactly, absolutely. So Dr. Thapa, in this situation now, this is a situation, the plaster has been given and this is the situation. What will you do when the patient comes to you after say 2 weeks or a 10 days time? Will you change the plaster or will operate this child or there is something else?
Probably there is a big angulation that I think the plaster has broken and there is some overlap has increased probably more. So I think it needs to be reduced, better and a better plaster or a stronger plaster should be given.
So what happened then? Absolutely. So, there are many situations which are beyond a surgeon's control. So this is the time when all doctors in the town went on a strike. And no anesthetists available, hospitals were shut down. So what the doctor did was to do a plaster wedging. So age-old technique from Chanley's book, he did plaster wedging, got a little bit of alignment. He could not get the right length. And what happened is, I'm just showing you from Chanley's book again. 1990 plaster is a fashion nowadays. But the problem with 1990 plaster is that there is a high risk of injury to the popliteal artery, because the knee is in 90-degree flexion. What I would suggest, what is safer, is to have, if you are giving a spica, the hip should be in flexion, the knee should be in flexion, but that need not be 90-90. If you have a proximal fracture, 45-45-10, middle shaft fracture 30-30-10, distal fractures 20-20-10. These values may vary a little bit, but these are the principles which we are going to follow. These are the angles which are given by Stiley. So in this patient, what actually happened was there was too much flexion, and because of that, the angulation was recurvatum. Now, when the plaster was removed and then patient came back to Bombay, after the holidays, this is what was the issue. The fracture healed well, there is no angulation, but there is 2 centimeters of shortening. and parents are worried. The mother is extremely upset. I want to ask Dr. Slongo. She asked me for the best international opinion. I said, let me ask Dr. Slongo, what should we do? How should I face the parents? What should I tell them? The mother is very unhappy. What should we tell? 2 centimeter shortening.
Yeah. Okay. It's a 6-year-old child. So for a 6-year-old child, 2 centimeter actually is not so severe. It looks ugly and the parents are not happy. But in this age group, you should convince the parents to wait at least 2-3 years and see what the nature will do. After 2-3 years, then you see what happens. And if there is no compensation, nowadays we go on the contralateral side for an 8 plate to modulate the growth. With an 8 plate, we show that means we break or we break the growing on the right side, and then we have the same length, but not actually. This is a big task we have as doctors, convince the parents that at least 2-3 years to wait, and not to go to another doctor.
So we waited for 2 years, and at 2 years, both leg lengths were absolutely fine, equal, because up to 2 centimeters of limb length discrepancy will correct in a child with fracture shaft femur. If given time, and this happens till around 10 years age. This will not happen if the child is older.
Yeah.
And perhaps for the participant, why this happens, the compensation of lengthening or the overgrowth is a combination of modeling time. We stop to say remodeling. Remodeling is completely wrong. It's a modeling time and consolidation time. As longer the consolidation goes and as longer the modeling takes, as more stimulation you have of the growth. Therefore, and as a child is younger than 10, you can wait. Exactly.
I want to ask one question to Vikas. See, if the child was 2 centimeters short and it became normal. If the child's limb length were maintained, would it give rise to a longer limb? Should we purposely maintain the limb shorter or give it equal lengths, if you have been given a choice to start with?
No, I would give a equal length. I would not purposely give a shortening, because overgrowth is not always necessarily happens. And it is more common if the fracture is near the growth physis, not in the diaphysis.
I agree. But anyway, we have in this age group we have to wait and we see what happens. But we will not accept in the long term 2 centimeters leg length discrepancy. Therefore, today we will not go for 2 centimeters for lengthening. We go for shortening. That means we stop growing on the contralateral side.
Absolutely. So what it means is if you have a fracture which is unstable, where initial shortening is more than 2.5 centimeter, that's not a good option for immediate hips.
No. Anyway, the goal of our treatment is to get the best result initially. Of course, if again, in the meantime, after my 45 years of experience in pediatrics surgery and pediatric orthopedics and trauma, no, our goal should be to restore the axis, the length, and everything as it was before. This was old-fashioned 30 years ago that we said, okay, because he's a child, we accept shortening, deformation. Of course, we know the nature will correct a lot of them, but the spontaneous correction from the nature, modeling from the nature, should be only a support of an optimal treatment. We should always go for an optimal treatment.
So I'm sure the audience is collecting all these gems which are coming from Dr. Slongo. This is the second gem you've got now. The gem is that you must do your best on day one. Exactly. You cannot,
rely completely on nature.
Leave it. Absolutely. You cannot leave it on nature to correct your mistakes. You must do your best. Nature is there to support you in case you have a little bit gone wrong here and there. But and then this is an example which will very well show what will remodel and what will not remodel. So this is a 7-year-old child with shaft femur. And again, these are the choices. I want to ask Dr. Vikas this time, what are your choices in this patient? We're going to go a little quickly because...
Yes, sir. It's a 7-year-old. So I would, in the diaphyseal fracture, so I would go with the elastic nailing, titanium elastic nailing.
Yeah, so, absolutely fine. Because this is a length unstable fracture and length has to be maintained. And Dr. Slongo is showing very well that... Absolutely. Again, this patient was treated in Spica. This was treated in an army hospital. Again, the reasons are different here. What I'm going to show is what happens if you don't do a correct conservative management. Again, it's not wrong if a conservative management is done, but you have to be much more vigilant and take care of L, S, and D, length, stability, and deformity. So here you see two issues. One was a deformity. There is a varus deformity, which is almost 20-25 degrees, which may not remodel. You see there is overlap and shortening, and there is 3.5 centimeter shortening as this child has grown. Now, what is not seen on the X-ray very well, you can probably see a little bit, but what is not seen on this X-ray is something what is here. So Dr. Pabin Thapa, when I examine the rotations of this child, if you see this child sitting, he's not able to sit cross-legged. Indian children want to sit. The left side is not able to sit cross-legged. So that mother noticed very well. And when we examine, you notice that you are not able to rotate on the fractured side. There is excessive internal rotation and less external rotation on the fractured side. So there is a rotational problem, a deformity of 30 degrees. So this child, we initially decided to wait and watch till the time the parents were convinced that something was wrong. The child is now 9-year-old, 2.5 years post-injury. And what he has is shortening of 3.5 centimeter. He has varus. Part of the deformity has remodeled in so much time. So from 20, we have come to 15 degrees of varus. But the main problem is that child has rotational problem. And because he wants to walk with straight leg, what actually happens is he's rotating his hip excessively while walking. And that has made a walking very, very funny. So now what do you do? At 9 years age, a malunited femur shaft fracture with shortening, what would you do now? I want to ask Dr. Thapa and then go to Dr. Slongo after that.
I think it's probably there's a rotational problem. So I think we have to, and also there's like 3.5 centimeter shortening. I think so we have to address both of them. So I think we need to have a corrective.
What is your choice? So you agree that correction is required, but how will you do that? What is your method? What would you prefer?
Probably with an external fixator on like a rail frame. So we do a corticotomy and then lengthen the femur. And then
what about rotations? Rotations, how will you correct?
I think after we do a fracture corticotomy, I think with alignment, I think we can get the axis also.
Okay, Dr. Slongo, what would be your choice?
I agree. I would go by external fixator. That means a rotation correction. I make it acutely, and then I go on with lengthening.
So this is what we did. We did a closed osteotomy. We just passed a nail so that would guide the growth. And what we did, when we pass the shank pins, you pass at different angles. So there is acute correction of rotation, acute correction of varus. Both are done acutely. And then all we require to do is just do lengthening over a monolateral fixator. And monolateral fixator is something which is very user-friendly for a child. He can easily bend his knees. It doesn't, circular frames really are required for this patient, and this healed very well. We removed the fixator and this child walked well happily ever after. So this was a conservatively treated patient which had a deformity. This is an 8-year-old child. Vikas, again coming back to you, shaft femur fracture. Now I think everyone agrees that elastic nailing should be done, right? Or some sort of nailing, some stabilization. And we did
it's very unstable
nailing.
Yes.
Since Dr. Slongo has 37 years of experience now in elastic nailing. So are you okay with this nailing or some mistakes we have done here?
But I'm very critical. This is exactly what I mentioned before. It looks absolutely well aligned. You cannot see any more diffraction nearly, actually. But anyway, for me, the orientation of the medial nail is not correct, absolutely correct. And when you look in the lateral view, entry point, that came from the entry points. The entry points are not in the best way. That means, the entry points must be on the same level. So actually it looks good, but there I see at least 3 failures in this, technical failures.
Yeah. So the Dr. Slongo is absolutely right. What this patient had was, excessive pain in the knee. And why this pain was there? Because the suprapatellar pouch is anterior. And any nail which is turned forward will irritate this pouch. And we had a hell of a time getting knee range in this child. And, what we had to do finally as the fracture healed up, we removed these nails. And then he had full range of movement, and we thought everything is fine, the problem is over, and the child is gone back to the game. The mother came back after 2 years and told us, my child is not perfect. That is the problem. And when we took the X-ray, and when we clinically saw the child, we realized that when he was standing, one ASIS was higher and one was lower. And when we did scanogram, we realized this child actually had 2 centimeter lengthening. So now this child is 10-year-old. He has 2 centimeter longer. He is a professional tennis player. And how should we manage, Dr. Vikas? How should we manage this child? A shoe raise, what is your option? A shoe raise or a lengthening on the other side, or can we do something on the same side?
Look, so the fractured side is lengthened?
Fractured side is long. So we promised the mother, we are going to give you perfect lens, perfect function, elastic nail. I've gone and attended Dr. Slongo's course.
We can go for the growth modulation on the same side. So we can do the shortening on the same side. Just put up 8 plates on both sides, medial and lateral of the femur. Yeah.
So we did that, and some technical sort of guidelines for people that when you do 8 plates for correcting limb length discrepancy, put longer screws. That's one technical point. Second technical point is put the screws in a divergent mode, because if you put screws parallel, the time to control the length will be longer. So these are small 2 technical points which I've learned from Dr. Peter Stevens, which I want to share. Yeah, Vikas, you were saying something.
Yeah, sir, I want to ask you one thing. So when you put a plate in the distal femur, do you slightly bend the plate to? So
it's a titanium plate. And it gets contoured, shaped to the contour anyways. So you don't purposely bend. Dr. Slongo, you want to say, you're trying to say something?
This is a very fantastic case to make some comments. First of all, exactly what I say always. Perhaps when a colleague will make a publication about complication, he will show such a case that, oh, look, elastic nailing is bad. We have the complication of new pain and so on. But he will not say that he make a technical failure. He will say the SN technique is not okay, or the material. So this is always the problem. Second point, leg length discrepancy. This was an absolutely anatomical reduction. That means, and we made a big publication about it. It means that the length of the leg was restored after trauma, after fixation. You never check the length actually at this point. So I say always the same example. If a child comes in with a femur fracture, before the fracture, he had a shortened leg of 1.5 centimeter. Nobody has realized this. And now he creates an overgrowth of 1.5 centimeter. And then you have equal lengths. And then, oh, fantastic. You are fantastic. If this child had, before the fracture, a leg length 1 centimeter more than the other one and made the fracture. And now she makes again the same overgrowth of 1.5 centimeter. So now she has 3 centimeter length and says, hey, doctor, you are a bad doctor, So this about leg length is a critical point. But here it's okay. I would treat it in the same way.
So this got managed very well just with in around 2 years' time. So again, remember that genu valgum correction, and if you do growth modulation, the correction is faster. And you are using it for limb length discrepancy. it takes little more time. So calculations are not the same. This took almost 2 years, and he finally corrected and we removed the plates. So one important thing is don't forget to remove the plates, because otherwise again this leg will become shorted. So I just want to end
for the next
thing.
surgery.
Then you can do this on the other side.
So I'll just finish with the last case and a small demonstration of what we do in this lockdown period, a COVID period, as a combi treatment. Something where sometimes where patients are not, it's not possible to operate the patients. So this is a 6-year-old child who had a shaft femur fracture, unstable fracture. She has a comminution and a perfect sort of an indication for doing an elastic nail. It's a proximal femur fracture. So we will take tips from Dr. Slongo and, do his curvature and, and make sure that everything goes right. But it was just not possible. This happened on 25th March 2020 when lockdown was announced in Bombay. All the hospitals were shut down. And, there was no way we could operate this child. What we did was put her in Thomas's splint. It was very difficult to get a Thomas's splint, as it would be difficult to get an elastic nail in Himalayas. Similarly, a Thomas's splint was very difficult to get in Bombay, but we got it manufactured. And, in our very simple from a welding thing. And what we did at 2 weeks, we removed the Thomas's splint and applied what is known as a single leg walking spica. So this is not my method. This is described by Dr. Jack Flynn. He has a publication, and those of you are interested, go to POSNA website, and then you have a complete video of how to apply a single leg spica. And people do all weird things with the spica on, single leg spica. So this girl could walk immediately with the spica because fracture was stable. And then, she could be carried by parents, and it was easy to take care of her. And now I'm very happy to say on 15 June, which was last week when she came for follow-up, she has excellent range of movement, rotations, and good length, because we have taken care of 3 things: L, S, and D: length, stability, and deformity. So as long as the principles are correct, the methods will follow. And with this, I want to invite all of you. I'm going to just, with permission, going to take 2 minutes more. I want to invite all of you to this conference, which is taking place in September. And you don't have to travel anywhere. It's going to be taking place on the internet. So you can watch this on the net. 8 sessions of pediatric trauma, something what we have experienced today, and so many faculty. And one very special faculty who is with us today, Dr. Theddy Slongo. And purposely, I have not said he's from USA or UK or Switzerland. He belongs to the entire world. Yes. And he's going to be with us. And he's going to give an oration on elastic nail. But everything is going to be covered. It's just 2,000 rupees or US $30 for anyone who wants to attend. And this is our website, ifix.in. So hope to see all of you there at this conference.
Sure. Thank you so much.
Thank you for that information.
Okay. Fantastic.
Thank you, Dr. Nagda.
We came to an end.
Though we have exceeded our scheduled time, we'd like to continue with the original agenda as we have an interesting topic lined up. So now I would request Dr. Slongo to start his session on when plaster treatment does not work.
Okay, so I will start talk about when plastic treatment does not work. Think in advance. That means we have to think always in advance when we start a treatment in a child fracture. So what is the goal of fracture treatment? Restoration of the anatomical axis, as we discussed in the case discussion, a stable fixation. What is important for us? No secondary intervention, healing within the age-related time, and restoration of the function, and no complication. And then we have to ask, what are the prerequisites? Get the perfect outcome in childhood. That means that we make a correct assessment of the fracture, that we have the knowledge of the modeling capacity. You see, I say modeling and not remodeling, age-related. We have to know this. A 6-year-old child is not the same as a 12-year-old child. Skills in conservative and operative treatment, especially in your country, I guess, the skills in conservative treatment, as we discussed before, and minimal effort. First treatment must be the definite treatment and outcome controls. So what means less or minimal effort? Effort, effectiveness, and results. Look at this picture. This is a forearm fracture, and I show you the healing picture. I said, oh, it's not so bad. But is this, the question is, how was this result obtained? So here I show the whole history. You know, I showed you only this picture and this picture. But this child had conservative treatment, bad function, refracture, plating, refracture, this, and with a bad outcome. This is the true story. And we should not treat the child that it came to this story. So therefore, for me, this is a question. Is there a state of the art for the treatment in general? You see, effort, profit, complication results, how we can order this. So this is, in practice, my order. I will have, at first time, best results with less effort, that means no remanipulation and no complication. That gives you happy children, happy parents, happy doctors, and low costs overall. This is important nowadays. So how we can achieve these goals? There are, for me, 3 ways. We can go for no manipulation, only immobilization, as we have heard in the first presentation about perhaps buckle fracture. This is, we can go for only no immobilization. Sorry. We can do manipulation, reduction, and plaster cast fixation, so-called conservative treatment. And we can make manipulation, reduction, and operative stabilization, intern or extern. Sorry. This is an example. No manipulation, only immobilization. Such a case as this needs only immobilization, not more, and no X-ray control. That's it. That's all. No mobilization is here the same. You see this fissure here of the tibia, plaster cast, finished, that's all. No more. That means no anesthesia, nothing. But here, in this situation, you need reduction, and then if you get a good alignment, as you see it here, you can make a plaster cast and conservative treatment. But as we discussed before, we should not accept this fix this in this way. No, we have to go for a correct reduction, and then you can go for a plaster cast if you believe it's stable. Or you can go for reduction and operative stabilization, as we have seen before. So we know in fractures in children always heal. But should this be free us of responsibility to deliver an optimal outcome for a child? However, we should not accept bad results, as we discussed before, just because it is a child, and we know a child adapts always. Nowadays, similar consideration for the indication should be made for children as for adults. Nobody of you would accept bad results. You, as a surgeon, you will have, after trauma, the same situation as before. That means perfect function, that the child had the ability to go to the later profession career. Early movement, playing school sports, no immobilization, no cast, simple care. So we have to consider always, when we start our therapist decision, can we go for non-operative treatment, cast, wedging, reduction and cast, or we have to go for operative treatment? This needs an exact analysis, really an exact analysis of the fracture. When we go to the literature, it's very contradictory and it's very strange. In the literature, very often, every literature about conservative treatment start, the best treatment option is non-operative. But in the text, then they say, no, we have to operate. Forearm fracture in children are the domain of non-operative treatment. This is also questionable. There are other literature, non-operative treatment for forearm fracture have a high rate of refractures, bad functional results, as you will see. So what is in Europe, for our view, from my view, the indication for non-operative treatment? Only stable and undisplaced fracture, that's clear. No manipulation, stabilization. Stable angulated fracture, that means they are stable but only angulated. Then we can go for conservative treatment. Unstable fracture only if stable reduction and fixation can be achieved. that needs a good assessment, what is stable and what is not stable. What is the goal of our treatment? Again, low limited effort, no remanipulation, purposeful, no therapy change, secondary operation, gentle, very often this is not so gentle, safe, we see secondary displacement, definitive, sometimes not, good results, this is a problem at low costs. Why operative treatment in childhood, as we discussed before in the femur session, came so popular? Because of the difficulties with conservative treatment leads to operative treatment. Problems with the fracture itself leads to operative treatment. Therefore, more and more we have the discussion about conservative treatment and their advantages and disadvantages and the bad factual results. So, in our view, what are the indications for an active operative intervention, reduction and stabilization? That means if the fracture is displaced, any segments, if the fracture is unstable, all segments, if in a forearm or a tibia or in lower leg, both bones are broken, Montecha lesion always, green stick sometimes, and refractures. Okay, so here is a good example. You see 3 similar cases, all proximal femur fracture, case 1, case 2, case 3. What was done in case 1? Case 1 was treated with a plate. I'm not happy with such a treatment, but it works, but I'm not happy with this. This is the second case, only a fissure. It was treated in a plaster cast, and here you see exactly what was in my talk about biomechanics. The plaster cast did not fix the bone inside. So because of the movement of the muscle, it came to a complete displacement even before it was not displaced. So here you have to go for a secondary intervention, and we stabilize this not in an optimal way. I can tell you this is not an optimal way, but it's good fixed, but you can do this in a better way. And this is the third case. You see the same fracture, primarily done with elastic nail. And this elastic nailing is fantastic. You see, the nail goes up to the physis of the head and so on. It's very stable. So you have to think about what is the best method. How we should treat nowadays green stick fractures. Very popular is that you try to reduce it or to break it and make a plaster cast, but you have still a deformity. And we know this deformity never models and has a high limitation of the ground supination. So nowadays we go for operative treatment. Here you see the literature why we do this. So this is an example, and nowadays, because of the bad results, even in this fracture, we go for operative treatment because conservatively you cannot stabilize and align this fracture. Important question regarding the bone segments. Are there different for the different bone regarding conservative treatment? Yes. Humerus is the best bone for conservative treatment, up to 80%. Forearm, only relative, because of the bad functional outcomes. We know it. There are 2 bones. Femur, as we discussed before, today mostly up from the age 3 to 4 in Europe. Lower leg, in principle, a very good indication for conservative treatment. Where are the dangers of conservative treatment? And here you see a fiberglass cast with badly padded and no soft cast. And when they open it, the patient had pain. And why he had pain? Because of this. Or you can see this. You know, I guess you know this from India as well. Luckily, in Europe, this is not. What we know about ligament ataxis, very often we go in this way, but this makes not so good ligament ataxis. This makes it much better when you make a study about this. So you see, we go in this way and not in this way. When the bone again looks, the bone is healed, this is the other question. There is a simple sentence. We have stopped to say the parents, no, the bone is healed after 4 weeks, 5 weeks, 3 months, 6 months. When we have to remove nails after 6 or 4 months, you know, in a 4-year-old child is different from a 14-year-old child. So today we say we remove a nail or a plate when the bone looks like a normal bone again, as you can see here. Here it's healed, but we will never remove it here. No, when the bone looks like a bone again. So this is the problem. You see, in conservative treatment, we remove the plaster cast and very often we see the refraction. So this is not a normal bone again. Again, elastic nailing, you see now the bone looks like a bone again, and now you can remove the nail. Since we go along this sentence, we never have seen refractures. Here you will have a refracture, but never here. So there is a treatment strategy principle 1. Only those fractures should be treated conservatively. These with the low tolerance range in childhood could be reduced and stabilized. This calls an exact analysis and the knowledge of the remaining modeling capacity. The second principle is only stable situation when conservative treatment is indicated, we recommend cast immobilization, as I mentioned before. Principle 3, if a general anesthesia is indicated for reduction of a fracture in childhood, then we aim for a definitive, stable and safe fixation. That means a potential unstable fracture should be reduced in the OR and we should be prepared for an operative treatment. The fourth principle, primary surgery is indicated in fully displaced and unstable fracture if secondary displacement can be expected, or if the child had previous reduction or open fracture. So in summary, the modern concept of fractured child treatment in childhood, what does this include? It is a combination of child-friendly treatment strategy, fracture analysis and classification, development of child-friendly methods and implants, and pain management and education. If the treatment is adapted to the character of the child, that means few pains, early movement of possibility to go back to playground and school, no or less care, short or no stay in hospital, and no functional disadvantages. How we should start the fracture treatment in childhood? With the fracture assessment. We have to analyze the child age, location segment of the fracture, the morphology, the stability, the potential for non-operative treatment, the modeling potential, and the own skills and equipment for non-operative treatment or operative treatment you have in your clinic. Thank you very much for your attention.
Thank you, Dr. Slongo. Now we move on to the last segment of the program, which is Q&A session. Due to limited time, we can only take few questions. So the first question is from Dr. Krishna Vaigaonkar. This is addressed to Dr. Taral Nagda. The question is, does every supracondylar fracture of humerus needs K-wire fixation?
So not every fracture requires K-wire fixation, but there are indications. So I will tell you type 1 fracture which are undisplaced, but those who have varus impaction will require to be reduced. And because they require to be reduced, they require to be stabilized or fixed. Type 2 fracture where there is excessive extension, or if there is a varus impaction, will require to be reduced under anesthesia and to be fixed. Displaced supracondylar fractures, gold standard of treatment is to reduce and fix. And I want to say again, just putting K-wires in any ways is not stabilizing or fixing. You have to plan your fixation very well. What I prefer is 2 or 3 divergent K-wires after getting a perfect close reduction. In some cases where there is medial impaction in adolescent patients, or if there is a medial comminution, I also prefer to do a medial pinning at the same time. So in my practice, I feel that almost 30 to 40% of supracondylar fractures, those who are in type 1, where I know that definitely there is no varus impaction, they will be treated by a conservative management. But most of the rest of the patients, we do tend to fix nowadays. Fixation is not just for, assuring alignment. The reason for fixation is to allow us to put a slab in less than 90-degree flexion and to avoid vascular problems. So this is something which must be understood by everybody.
On the short comment, go to the pediatric EU fracture classification of children, and then you will see an algorithm when we go for a reduction, fixation, and conservative. Okay?
Okay. Any other comments from the panelists on this? So I'll move on to the next question. This question is directed to Dr. Pabin Thapa. The question is, how are the casting techniques different when it comes to children vis-a-vis adults? So the question is, how are the application techniques different when you do casting in children versus casting in adults?
I think probably the casting techniques are more or less the same. Like we need to properly align, reduce the fracture properly first, and then the techniques are basically different. But only we have to be careful about the paddings and these things. I feel that.
I agree. Padding is different in adults and children because the child cannot tell you where is the pain and so on, and you need a good padding because of the swelling. But the 3-point support is in adult and in children the same.
Okay.
Next question.
So we move on to the next question. This is from Dr. Sudhanshu Pandey. The question is directed to Dr. Vikas Basa.
Yeah.
This question is, what is the management of juvenile till-ox fracture?
Juvenile till-ox fracture.
Till-ox fracture.
Yeah, so their anatomical reduction is very important because it is an intra-articular fracture, say epiphyseal fracture. So whenever needed, you may even fix it with a screw.
Yeah, absolutely. So I'll just elaborate. It's a telos fracture. The X is silent here. So it is a fracture where the lateral part and anterior part of the lower tibial physis is fractured. It's a very interesting fracture because in children, the part of the medial part of the epiphysis are already fused. So whatever remains fractured. It's a very interesting fracture. Since it's an intra-articular fracture and also it is next to the fibula, it's very important that we anatomically reduce it and fix it in a very stable way. So the reduction is either close reduction with arthrogram, or many times we have to do an open reduction if the fragment is completely tilted. And this needs to be fixed with a trans-epiphyseal screw. A K-wire will not be able to stabilize this well. Yeah.
That's correct.
We need a compression and stability there. Yeah.
And one more thing is, it's very important to do a CT scan before treating this patient. Just on basis of X-rays, you'll not be able to treat that.
Right.
I have a comment to this. Switzerland is a rich country, and why is Switzerland a rich country? Because we spare money. And in our clinic, I guess over the last 20-25 years, we did not one CT scan in a TO or three-plane fracture, because once you have made my workshop and you know how the normal situation is, then you can manage this without CT scan. Only CT scan, we go for CT scan if we see on the X-ray, this is a little bit different from the normal TO fracture. But if we see, fracture this way, fraction this way, fraction this way, it's the same. You can do this if you study the fracture, but only to spare money, or even for India.
Okay, so moving on to the next question. This question is directed to Dr. Theddy Slongo. The question is, since there are many cast materials available in the market, right from plaster of Paris, fiberglass, and even polyester material, which is both, it can be either rigid or it could be semi-rigid material. So how can a doctor choose between these different materials when it comes to casting a child?
Nowadays, depends always what is the goal of your fixation. If you have a very unstable fracture, of course, and you will treat this with a cast, even with fiberglass cast or not, stability is important. But nowadays, we go always with this combination of soft and rigid. That means the soft cast gives the envelope around the bone or the soft tissue, but allows some biomechanical movement and movement. But on the same time, in the correct position, we give the splints with the fiberglass, the hard one. That means this gives the stability. It means in a lower leg, if you have here a bone, and then one splint here, so in the lateral view, it is stable in this way. And then perhaps we have a splint on this way, and this gives stability on this way. But still, the plaster cast remains a little bit flexible. If you are using only plaster of Paris, of course, this is not possible. Then you need circular or splints, as you have seen before. In our situation, even in fresh fracture, when we go for plaster of Paris, we make the splint or one bandage, then the splint, because the splints gives the stability, not the circular situation. And then after 2-3 weeks, of course, then you can stabilize it more.
So I agree, using a combination of the material, the advantage is you get stiffness in a plane where you require. But if the inside is soft, it allows you to cut the plaster very easily and make it very, very comfortable for the child.
Yeah, absolutely.
Secondly, different fractures, the preference is different. For example, if I have a torus fracture of lower end of radius, a very soft plaster is important because you don't need any rigid plaster.
Yeah.
However, if it's a weight-bearing bone, so if I'm giving plaster for ankle or tibia, I need some slabs of rigid material because a soft plaster will not do that. So every clinician or a hospital will have to stock all different kind of plaster. And I am very happy that Articast has that option that you have different plaster ranges available with us.
I think nowadays nearly every company who produced fiberglass casts has soft cast as well, because this is a must. Okay, next question.
Yeah, so next question is directed to Dr. Taral Nagda. The question is there a role for casting or splinting in an operatively treated pediatric fractures?
Absolutely. So there are two reasons why we still would splint or plaster an operatively treated pediatric fracture. I'll give you an example of femur fracture which has been treated by elastic nail. We generally use a knee immobilizer for these patients because there is some soreness or some synovitis around the knee joint. These patients are uncomfortable to move the knee joint, so we do give a knee immobilizer after the plaster. There are some patients who have unstable femur fractures. So in unstable fractures or unstable forearm fractures, sometimes you may have to use an additional slab or a plaster for a short time till the time the fracture gets stabilized. The third indication is tibia fracture. Tibia is a very funny bone. See, forearm and femur are circular bones, and the principle of elastic stability works very well over there. Now, tibia is a triangular bone. And because tibia is a triangular bone, I've realized that when we do elastic nailing of tibia, many times we do need a plaster to control the other forces. Otherwise, the fracture tends to go into recurvatum or procurvatum. So, if required, there is no harm in giving plaster, but that is given for a very short time along with an operative management. Nowadays, if there is a fracture shaft femur which is unstable, what we've been doing is addition to an elastic nail, we add either an external fixator or a plate, a sliding plate. So there are a number of cases where I've done elastic nailing and did a sliding plate for rotational control. And so LSD, lens stability and deformity correction has to be maintained whichever way you can. Dr. Slongo, your comments.
Yeah, I'm not so happy with your because in our now 37 years of experience with elastic nails, thousands of femur fracture, we never did really an additional plaster cast even in femur for stability. Yes, I agree. Some parents are very afraid child has pain or you have something additional. We give a splint for immobilization for 1 week or 10 days, but not for additional stability. It's only for comfort and pain management. Because again, the elastic nailing, and we know it. We did thousands of cases. We know it. If you make it perfect, you don't need additional fixation. And especially now for the femur, look at this picture here. Before you go for a plate or something like this, then go for these small, simple end caps. This gives you a high stability. Even in nowadays, we do this in oblique fractures, never in a transverse fracture. Then you will make a pseudotrosis. But oblique fractures, long spiral fractures, or simple comminuted fractures, with these end caps, you can stabilize it. And therefore, I guess we shouldn't say as a recommendation to make always a plaster cast. We should say a plaster cast you can apply for comfort, pain management, or something like this. But your osteosynthesis should be stable enough. You agree?
Yeah.
Yes.
So we move on to the next question. This question is addressed to Dr. Vikas Basa.
Yeah.
The question is, in acute ankle fractures in children, there are usually two options. One is casting and the other option is removable ankle brace. So the question is there any clinical evidence to show which one has a better outcome?
I would go with the casting because that gives a rigid immobilization. So at least for first 2 to 3 weeks, I would go with the cast immobilization, and then later we can wear them with the cast brace.
Okay. Any additional comments from the panelists?
I agree.
Dr. Vikas, what about the
fracture, ankle sprain? What is the question?
It's a fracture.
Ankle
So the
fracture.
question is in acute ankle fractures in children.
Yeah. So acute ankle fractures, brace has no role apart from sometimes isolated Salter Harris 1 undisplaced fibula fracture. That's the only one which can be treated with a brace, but rest everything requires either a plaster or operative treatment. So in fact, the choice is not between brace and plaster. The choice is between plaster and a surgical management. And X-rays sometimes look very innocuous. So these X-rays need to be looked at, and fascial injuries in children, need to be accurately reduced and fixed because they are shear forces, and you need compressive forces to overcome these shear fractures. So,
and even for the
please, Vikas.
Yeah, even for that matter, when they come with the ligament sprains in ankle, which is very common in sports injuries, it's always better to do a cast immobilization because in children the ligaments are as strong as bone.
I agree. Good.
Yeah, next question.
Next question.
Yeah.
So this question is again directed to Dr. Taral Nagda. In femoral shaft fractures which are isolated, what is the role of hip spica casting?
Okay, so children, I will just summarize the treatment as age goes. The children who are less than 6 months, we prefer to treat them with polyc harness. We don't use Bryans or gallows traction as it was used 20-30 years back because it has its own problems. These children are difficult to manage in spica, so we use either a brace or polyc harness. Children who are more than 6 months age, up to 3 years, I prefer to treat them in a spica. Children who are more than 3 years, up to 6 years, I either will choose spica or nailing depending on the fracture profile, the obesity of the child, and preference of the parents. Children more than 6 years, I generally treat them with elastic nail. But towards increasing age, 11 years plus, heavy children, sometimes we do use lateral entry interlocking nails in those patients. There are fractures which are not absolutely ideal indications for elastic nail. For example, very distal fractures or very proximal fractures, and one has to be innovative in treatment in these fractures. Of course, and when you use elastic nail, you have to use with a lot of skills and planning in those patients. So, it's very important. So there is an option of plating at extreme fractures, but you can use elastic nails in those patients. So that's how I decide. There are many other factors which will decide whether it's a closed injury or open injury. That will also determine how I'm going to manage. If there are multiple ipsilateral fracture, shaft femur with shaft tibia, you tend to fix both in most of the children. So a lot of factors will matter here. I hope that answers. If any additions from Vikas, Dr. Slongo, Or Dr. Praveen, please.
Yeah, agreed.
We agree. Yeah.
Yes.
One last question before we conclude this session. The question is again directed to Dr. Theddy Slongo. What is the ideal management for buckle or a torus fracture?
Yeah, as I mentioned in my talk, a torus or buckle fracture is a stable fracture. So depending on the age of the child, the pain of the child, we go only for elastic bandage, no X-ray control, or that only by a fiberglass split or a circular frame, a soft cast, cast for this extremity, but only for 3 weeks. No more control, no X-ray control, merely. This is really forbidden in our clinic. If somebody is asking the patient come back for an X-ray with a torus fracture, then he will be criticized that why you go again. No, this is exactly fracture evaluation. If you decide this is a torus or buckle fracture, okay, it's not displaced, stable, not angulated, I will fix it only for pain management, not more. It's a pain management. 2 weeks, 3 weeks, and then let it free. No more X-ray. We know, because we know it will heal and it will be stable and will not be angulated. So if you are unsure, not sure that this is a buckle fracture, of course, then you have to control it. But then perhaps ask a colleague and said, it's your opinion, is it buckle or not? Yes. Okay.
So buckle fracture, I just want to add, is a failure in compression, and it will buckle only on one side and it's stable. Yeah. But if you have buckle-like looking fracture on one side and tensile failure on the other side, it's not a buckle fracture, but it's a green stick fracture. And that needs to be stabilized. So, that differentiation must be known.
Yeah, that's a good comment. Thank you.
I have a question to all the panelists. Yeah, I have a question to all panelists. See, whenever there's a fracture, and we being the pediatric orthopedic surgeons, we manage with the cast. The fracture is well reduced and it is behaving well, it's doing well. The pain is also well taken care of. But the main problem is itching. The child is very irritable, because it's very itching. It's not the pain, it's nothing. So I wanted to know from the panelists how you tackle this itching. So long the child is in the cast. Because in the middle of the night, mother calls up and says, my child is irritable because it's itching inside. So is there any remedy? Because I usually recommend them to use hair dryers to blow the air. So I want to know from the panelists, is there any other option to take care of this itching when they are doing very well in fracture reduction and healing process?
According to the recommendation of Lutz von Lahr, who was a really very experienced and wrote a good book about fracture management, if a child says, I have pain or feel uncomfortable in the cast, in our clinic, it's a must, because distances are not so big as in India. All patients are very close. That he has to come to the clinic that we see, okay, everything is okay in the cast. No, the pain is only from this, can go back. But your trick is okay. But the situation in our country is different. There are very short distance, very close to the clinic. But then this is the role that we have to check it. Because the child, we say, there is a statement, the child in the cast has always right.
Yeah, we have to respect his complaints.
Exactly. So, but your trick is fantastic. You can make this trick first, and then if it does not disappear, I guess you have also to control.
So one of the thing I want to mention is the trick is in preventing. And if you have seen Dr. Slongo's video, some of the things which he has done are really important for preventing itching. One is to use a very good quality cast padding.
Okay.
And in India, because it's very hot and humid, a cotton cast padding is better than a synthetic cast padding. Okay. Because children don't tolerate the synthetic cast padding very well. You can use it, for a plaster change, but for a primary plaster, use a cotton cast padding. Second thing, what we use is, use some kind of powder, before putting the cast padding, so it is taken care of. And third thing, I always do what Dr. Slongo did. That whenever you have creases, you don't want foldings. If there are folds, then it causes more itching and discomfort. So it should be absolutely iron, iron smooth plaster as he has shown.
Right.
So if you practice what he has done, it's very easy. And lastly, I agree that all the complaints should be taken very seriously, because when mother says itching, we really don't know whether it means
itching or exactly
what is the meaning of that itching. We really don't know. So it's better to have the child come to the clinic and be seen by somebody, especially when the call is at middle of night.
Yeah.
Okay.
So in the interest of time, we have to conclude this Q&A session. Before we end the program, I would like to hear final comments from all the panelists. So starting from Dr. Vikas Basa.
Yeah, it was fantastic. I really enjoyed the discussion. Very good. Thank you so much.
Dr. Pabin Thapa.
Thank you very much for this, and it was a wonderful session being with so much eminent pediatric surgeons in this field. Thank you very much.
Thank you. Dr. Taral Nagda.
Yeah. What I want to say is that one session with Professor Slongo is not enough. And,
I agree.
I would request you that,
there's a lot to learn from him.
Yeah. So if you're talking about plaster treatment and conservative treatment of fractures in children, see, most of the trauma which occurs in children, most of it is treated conservatively. But when you treat, the treatment is simple if the principles are known. So I would request the organizers, if it's feasible, have more sessions so that we can cover more. And thanks, Dr. Slongo, for sharing all your wisdom. There is always so much more to learn from every word of his and every slide of his. At the same time, I have learned a lot again from Vikas and Dr. Pabin Thapa. And
thank you.
I think this session should have one more edition. That's what I feel. Dr. Slongo, your comments?
Okay, thank you very much. Also from my side, first of all, to the participants, I have seen we are more than 500 attendees, and that you spend so much time. We have a little bit more than 1 hour, but I guess it's important. And I learned a lot, and I have seen a lot of your presentations, and also the technique works very well for this webinar. We had no big problems, but anyway, webinars are fantastic and gives a good communication. But at the end, I like much more face-to-face teaching in courses and workshops.
Exactly.
Much better. But in this situation, we have actually, and also for financial reasons, we should continue with this communication, with these webinars. I enjoy to do this work, but it's difficult. And thank you all to you, my colleagues here in India, to organize this. For me, it was a big fun, and I enjoyed it, and I like to do this work. And if you ask me again, I come back.
Yes, absolutely. Hope to see you soon, Dr. Slongo.
Thank you. Okay.
So with this, we come to the end of this program.
Have a nice day.
So we come to the end of this program. A couple of announcements before we leave. Firstly, on behalf of SCT and EVO Alliance, I would like to thank all the faculty members and the participants to making this session a great learning experience. I would request the participants to share their feedback on the email ID mentioned on the bottom of the page. And if any of your colleagues or team members could not access this live webinar, they can access it over the next 30 days using the same link. And about the next live webinar, which is going to be scheduled on 27th June, which is again a Saturday, from 1 p.m. to 2 p.m. And the session would be on management of clubfoot and developmental dysplasia of hip, challenges and tips. And to lead this session, we have Dr. Amit Nimade, who is an assistant professor of orthopedics at NKP Salve Institute of Medical Sciences and Lata Mangeshkar Hospital, Nagpur. We also have Dr. Matthew Varghese, who is the head of Department of Orthopedics at St. Stephen's Hospital, New Delhi. We are again privileged to have Dr. Theddy Slongo in this session as well, leading this session. And we also have Dr. Sunil Vijay Singhe, who is a consultant orthopedic surgeon at Lady Ridgeway Hospital for Children, Colombo, Sri Lanka. So we hope to see all of you and your colleagues in this webinar next Saturday on 27 June from 1 p.m. to 2 p.m. Thank you once again, everyone, and please stay safe. Bye-bye.
Thank you. Bye. Take care.
Bye.